sounds. Because again, that way, when they give you the physical exam for the patient, the sound that they give you, folks, tells me a lot about what's going on. That means you got to understand the physiology of these sounds. Stridor is that noise. When you breathe in too hard, your exothoracic airway narrows. Okay, that's what stridor is. Remember, wheezing is narrowing of the intrathoracic airway. And of course, there's a long differential for each one. All you got to do is just say it, though, Melissa. Just talk it out. So when somebody has stridor, you say, I need something narrows the exothoracic airway. And then you'll see it. Like if you have a small jaw, like Treacher Collins or Pierre-Robin syndromes, micrognathia, big tonsils, big adenoids, retropharyngeal abscess, peritonsils. I mean, you just come up with a differential. It's a long list. But the key thing is, it's only between here, the lip and the glottis. That's what I mean. You got to be able to talk it out. Don't try to remember some list you read somewhere. I need something in the exothoracic airway to narrow it. And then you'll see there's only one answer on that list. That's what I mean. The test writer congratulates any student who's organized. And then realize it's not about knowing every detail there is in a book. Is your mind organized? Because a doctor's mind has got to be organized in your airway. Now, if you got wheezing when you exhale, that's normal. So if somebody's breathing in like this, you hear. So you wheeze only when they exhale. Just. All right. Now, whenever anybody wheezes on inhalation, that's never a good sign. Because on inhalation, your intrathoracic airway is supposed to open wide like this. And yet I'm hearing wheezing. That means there's something big in the way. Everybody follow? Or the airway is completely narrow like that, like severe bronchospasm. So anytime you hear wheezing on inhalation, that person's in bad shape, whether you knew it or not. So here's a question I remember seeing on my boys years ago. It says you're the physician on call. Yeah, physician on call in the ICU. You get a call. You're a physician on call in the ER. You get a call from the ICU and it says we're down to our last bed. Okay, I'm sure that came up with COVID, right? We're down to our last bed. And then 2 patients walk in the ER right after that call. It says one person has real loud wheezing on exhalation and the other one has real soft wheezing on inhalation. Who gets the ICU bed? Justin. All right, Cesar. The one who's wheezing on inhalation, period. Notice how they made it soft, as if it doesn't mean anything, versus real loud on exhalation, as if that means something. Is the phase that you hear it in that means the most, not how loud or soft it is. Okay? All right. Bronchi, air moving over mucus. Who has mucus in their airway, Anna? Restricted or obstructive?
Hey, excuse me, sir.
Wait a minute, Mabel. All right, go ahead, Anna. Who has mucus? It says mucus over in the airway. So all obstructive have bronchi. All right, Mabel, you have a question?
Yeah, please. I didn't understand what you explained on somebody is on call on ER and got a call, maybe a call from ICU. I didn't understand the example you gave.
All right, I said you get a call from the ICU that you're down to your last bed. That means only one person can come in the ICU. Do you understand that?
Yes, sir.
Okay, 2 people walk in the ER with shortness of breath. One has real loud wheezing on exhalation. One has real soft wheezing on inhalation. Who gets the ICU bed, Mabel?
I don't know.
No, figure it out, Mabel. You don't have to know. Figure it out right now. Which one bothers you more? Somebody who's wheezing when they inhale or wheezing when they exhale? All right, Gloria, help her out. Any wheezing when you inhale, Mabel, is a bad thing. I just said, either you got an airway that's wide open, but there's a big mass in the way. That's not good. Or you got an airway that's not open at all. You got severe bronchospasm. Okay? Any wheezing when you inhale, no matter how soft or loud, is a bad sign. That person needs to be in the ICU. Okay? And that was the point they were trying to make with that question. Okay? You understand that, Mabel?
Yes, sir. Thank you.
All right. So rhonchi, air moving over mucus in your airway. So all obstructives have rhonchi. Crackles, we've talked about this several times. Crackles means airway that was collapsed or popping open. Who has airways that are collapsed most of the time, Mabel? Restricted or obstructive?
Sir?
Who has alveoli that are collapsed most of the time? Restricted or obstructive?
Obstructive.
No, obstructive has airway that's open all the time because it's got carbon dioxide stuck in there. Nicholas, brush it.
Yeah, restrictive
Why restrictive, sir?
because of the fibrotic destruction.
Yeah, because they have fibrosis. You understand that, Mabel? Always got to tie it to something physiological to remember these things. All right. Crackles are much more common than restrictive. They all have it. From day one, they have it. Why? Because the interstitial disease causes fibrosis and alveolar collapse. Obstructives get it late in their disease. When mucus clogs up the whole airway, then that airway will collapse. Or they got pneumonia or something. Something's got to be there for them to get it. Not that they don't have it, but all the restrictions have it from day one. Yes, sir. Yeah, flush pulmonary edema will cause crackles, yes. Because the fluid will wash away the surfactant in the interstitium and cause alveolar collapse. Yeah. Yeah, it has to be, crackles always means you got collapse of the alveoli, always. All right, that's lung sound. Other lung sound, decreased breath sounds or dullness of percussion. Says there's something between the lung and the chest wall. And that something, Miguel, is absorbing the noise. What it is, you don't know, but you know where it is. That's the key. So when I look at the answer list, I say, I need something between the lung and chest wall. Oh, hemothorax. Okay, blood. Soon, I'll take it. Oh, fluid effusion. Oh, okay, fluid. Okay, fine, I'll take it. He's got mesothelioma. Oh, that's a mass in it. My point is, you better pick an answer that between the lung and chest wall. And stop trying to memorize lists. Understand the physiology of these lists so you don't have to remember them. But you can say it again to yourself, look at the list of answers, you'll see there's only one answer where you want it. All right. Next one, increased firmness. Means you have consolidation on the same side or atelectasis on the opposite side. Or you can make the same conclusion when you have bronchophony, egophony, or E to A changes. I say the letter E and it sounds like the letter A. It means, again, consolidation on the same side and atelectasis on the opposite side. So let's say you got increased firmness in the left lower lobe. What are your two choices, Edna? Increased firmness, left lower lobe. What are your two choices? No, not obstructive. I never use obstructive here. No, I didn't say restrictive either. Okay. Gloria, what did I say? Yeah, because that's what I'm saying. Look up at the screen right there. There's no obstructive on there. It says consolidation. Where, Gloria? On the same side. So consolidation in the left lower lobe or atelectasis in the right lower lobe. That's what I mean. Same side or atelectasis on the other side. Because if you got atelectasis on the other side, that means the airway is collapsed. That means you're not really hearing anything here. That's why it looks like there's more firmness on the normal side. Melissa. Yeah, if you have, yeah, so she was saying it was a question that she did, and they said decreased firmness. That means something's absorbing the noise. That's the same thing as saying dullness of percussion. Yeah, that was fluid. Yeah. Again, remember, a test writer can say things in a different way, but he's still saying the same thing. Yeah. So that's all it was. They just changed the word. It's a word game, folks. It's always been a word game. All right, tracheal deviation. So Jess, your trachea deviates away from pressure, pneumothorax, on the opposite side, or towards atelectasis. Because when you collapse part of the airway, you create a vacuum on that side. So if your trachea deviates to the right, Jess, what are my two choices? Right atelectasis or left pneumothorax. Then they'll give you a second finding to know which one they want. So trachea deviates to the right with decreased breath sounds on the right. And Jess says the diagnosis is what? Atelectasis on the right. Right. Remember, trachea deviates to the right. So they gave you a finding that goes with the finding on the right. Pneumothorax is on the left. They didn't say anything about the left. That's what I mean. You got to have two findings to narrow it down to one choice. And that's what they give you on the exam, folks. Because they figure you should know the two, and then here give you evidence for one. There it is. You should know the answer. You should never be guessing. They will give you all the findings. Okay, or put only one of them on the list. But you got to know how to think it through with these lung sounds. Very valuable. They always give you the pulmonary exam, folks. They don't hide it from you. All right, but the finding on the exam will tell you exactly what's going on in the lung. Yes, Lauren. Pneumothorax and hemothorax, yes, can also give you deviations to opposite side because both will apply pressure. So now finally, hyperresonance. Hyperresonance says there's extra air in that thoracic cavity, i.e. pneumothorax is the worst it can be. Okay, so when you have hyperresonance on one side, think pneumothorax on the same side. But what if you have hyperresonance on both sides? Think hyperinflation, because now you have extra air on both sides. Like asthmatics, COPD, when they come in, they're overinflated on both sides. So hyperresonance on both sides, I think hyperinflation. Hyperresonance on one side, I think pneumothorax. So trachea deviates to the left. Zena, what are my two choices? Right? Pneumothorax where? Pneumothorax where? Give me location now. All right, Steve. Pneumothorax on the right because I'm pushing it towards the left. Pressure pushes the opposite side. All right, so everybody is listening because you got to be able to take a look at that lung exam. You should know what it is already. All right, notice almost every pulmonary question we've had in the morning, we got them right. That's because I just focus on these sounds that they tell me. The sound tells me what's going on. But if you know what these sounds mean, you're gonna have a hard time figuring out what it is. Okay? So trachea deviates to one side. That means pressure on the opposite side or atelectasis on the same side. That's the way you should interpret. And then they give you a finding to tell you which side something is on. So hyperresonance. All right, Ryan, you have a question?
Yeah, so can you go back to the previous slide?
And your question is?
When you have when your trachea, so in the case of the trachea deviation, it'll be if it deviates to the right, you have a pneumothorax on the left, atelectasis on the right. You have increased tactile vocal fremitus on the right as well.
Trachea is deviating to what side again? To
The right.
right? If you get deviates to right, that means you have atelectasis, you're gonna have decreased fremitus on that side because the lung is just not there. It's collapsed. Remember, that's what atelectasis means. So if you want to use fremitus, then you have to say it that way. They usually will say decreased breath sounds on that side because if you got a collapsed lung, there's no air moving through it.
Okay.
Yeah. All right. Lung infections now. And there's clues. Listen carefully. Croup is subglottic edema. It means you're going to have narrowing of the airway right by the glottis. That's still considered extrathoracic airway. So what do you hear? Stridor. Stridor and barking cough. Bark, bark, bark. Sounds like a dog barking. So when a kid comes in with croup, I say, hey, did the dog next door start barking at you this morning? Yeah, how'd you know that? The dog heard a bark. That says a new dog. So then, you know, Jeremy said, oh, there's a kid next door. So Chihuahua shows up with a rose in their paw. He said, what's up? Anyway, stridor and barking cough equals croup. What do you see on the neck film? It's called a steeple sign. That means the narrowing collapses your trachea like this. So you just see a little column of black air moving through the middle. Steeple sign. Looks like a steeple on x-ray. You understand, Melissa? So that's croup. Bronchiolitis is, we call it infectious asthma. That means asthma-like symptoms caused by an infection. Okay? So it has all the signs and symptoms of asthma, but it's an infection. And that's typically what we assume if you're under the age of 2. Bronchiolitis has all the signs of asthma, but asthma persists after age 2. Bronchiolitis does not. I found out the lung is normal adult size at age 2. Then I realized why bronchiolitis disappears at age 2. I always wonder why they always said it should be gone by age 2. Now you know. 4 most common viruses for this. Influenza. %80 of the cases. So if they ask you what's the most common, you have your answer. RSV. 15% of the cases, but this is severe, folks. So if the person's in the ER or in the hospital, I pick RSV because that's what they want. If you go to the hospitals right now, February, oh, pick RSV. So you see RSV on so many doors. The fact is they're in the hospital. That means it was a severe case. Mild cases don't even come to the hospital. Mom will just call you and say, oh yeah, he's doing this. Oh, that's just bronchiolitis. He'll be okay. So the key is to recognize it, diagnose it. What do? Nothing, because they usually go away on their own. They're viral. Okay, they're viral. After RSV, there's adenovirus and influenza virus. That's the top 4 for both the illnesses. It's just peak flu season, peak RSV season. You hear it all over the news. So there's a whole lot of croup and bronchiolitis in the hospitals right now. But if they're in the hospital, ER, pick RSV. That's all I'm telling you. But if they say what's the most common cause, then you have to say pure influenza. RSV can be treated with a drug. Anna, name a drug. Which one? Yeah, palivizumab. Viz. That in the middle is supposed to be a virus, RSV. And then motivizumab. And then what's the other one? R. Ribavirin. You can use that as well. Okay, that's for severe cases. Most cases you don't have to treat. All right, bronchitis means increased mucus production, Zena. Somebody says, Doc, I've been coughing up more mucus the last 3 or 4 days. Okay, you got bronchitis then. So historical diagnosis, you don't have to run any tests or even listen to the chest. You got bronchitis. You got increased mucus production for 3 or 4 days. That's acute bronchitis. Chronic, that's less than a week, is acute. Chronic bronchitis is you've had increased mucus production for at least 3 consecutive months of 2 consecutive years. That's your chronic bronchitis, also known as the blue bloater. Acute bronchitis, you've been coughing up extra mucus for less than a week. Chronic bronchitis, you've been coughing up extra mucus like a smoker. You've been coughing up for years, so easy to make a diagnosis. For at least 3 consecutive months of at least 2 consecutive years, we call it chronic bronchitis, i.e. the blue bloater. The most common cause of bronchitis, Josh. What? No, all of them are going to cause inflammation. You can't say inflammation is the cause. What's the underlying cause? Who? Not asthma. Melissa, most common cause of acute bronchitis or chronic bronchitis. Which one? Infection due to what? What? Not influenza. You're close though. Cares. Adenovirus. Don't forget, viruses are way more common than bacteria. You already know your brain's got bacteria because that's what the book said. They don't even mention viruses in the books. I don't know why, but they didn't. I told you, you got to know the truth for yourself because there's a lot of stuff left out of books. Okay? The majority of infections are viral. And now I'm seeing a lot of questions. Why? Because of overuse of antibiotics. It's caused a lot of resistance. And they're telling doctors, could you please remember, viruses are more common. Unless the person really looks bad, don't treat with antibiotics. It doesn't make a difference anyway. There's so many studies that show antibiotics don't make a difference in any of these viral infections. That means unless they look real bad, don't treat with antibiotics. It's just symptomatic treatment only. So adenovirus, number 1. If they want a bacteria, that's less than 10% of the time. Then it's strep pneumonia, H. influenza, Neisseria catarrhalis. Anna. Yeah, you can call it that, laryngotracheitis. Yeah. No, croup is upper airway. Bronchiolitis, bronchioles, is lower airway. One has wheezing, one has stridor. So that's why you can't call it the same thing. Infectious agent is exactly the same. It's just that when infectious agent is just coming in, it affects up here first, then it goes down and affects. That's why you can get both. Yeah. All right, so chronic bronchitis, acute bronchitis. All right, pneumonia means you have consolidation. Consolidation means airway, mucus, and germs packed together. What are you going to hear when I listen? Ida. We have consolidation. Let me ask Mabel. What are you gonna hear when somebody has consolidation, Mabel?
You're going to hear crackle.
You could hear crackles, but there's one that's more specific for consolidation. Leslie, you're first.
Increase parameters.
Increase fremitus. Again, exercise your knowledge, folks. I mean, they'll say all these other things, but fremitus tells me for sure it's consolidation. Okay. All right. So airway pneumonia, consolidation, increase fremitus. Interstitial pneumonia usually doesn't have an airway problem, so they have crackles. They force your alveoli to collapse. So airway pneumonia is bacterial. Top 3 bacteria, same list I just gave you. Strep pneumonia, H. influenza, Neisseria catarrhalis. Ida, what's the first line drug for community-acquired pneumonia? CAP. First line antibiotic. Ceftriaxone is IVIM. You don't need to get that big. Community-acquired means it comes in your office. Just give a prescription for what drug, Melissa? Which one? Levaquin? No, that's too much. That's overkill. Let me ask Gloria. It's amoxicillin, something simple. Tastes like cherry gum. Easy to, yeah, amoxicillin is first line for all respiratory infections. Giving it to you now. Okay, all of them. They say start with amoxicillin because it covers them very well. And it's cheap and hardly any resistance. Okay, if they're not better in 7 days, repeat, but add clavulanic acid, augmentin. Okay, and they clear up. Majority of times they clear up. You don't need big gun antibiotics for community-acquired pneumonia. Yes. Yeah. Yeah, they've changed it. There's some macrolide resistance that they're running into now. Yeah, right now, amoxicillin, this was the last, what's they call a meta-analysis that they did. Amoxicillin covers it better. Now, if they're going to hospital, that means community-acquired pneumonia that's bad enough to end up in the hospital, and they want ceftriaxone, which covers all 3 of these bugs, plus you add azithromycin for the atypicals, just in case they pick one of those up. Okay, but this is community acquired, means it's in the doctor's office. Doesn't need to be hospitalized. Amoxicillin. But if you're sick enough in the ER and I gotta hospitalize you, no, I gotta cover some extra stuff because you're going into the hospital. You might pick up some other stuff while you're there. All right, ceftriaxone and azithromycin is the combination currently being used, and I'm seeing it in a lot of test questions. So again, I'm giving you an update so that you just know that, pick that. All right, so airway pneumonias. Interstitial pneumonias are non-bacterial. I'll go through them later. Tracheitis, most common cause, bacteria, Staph aureus. How do most people get it? When they're being intubated. Is the intern again, trying to get that tube in there, and he brushes it right up against your cheek and just grabs Staph aureus before he gets into your trachea. Now you have Staph aureus in your trachea. So they'll ask, what's the most common way to get it? The answer is during intubation. Okay, tracheitis. How do we know we have it? The nurse will tell you, oh my, I'm suctioning a whole lot of pus out. That's how you know, all full of pus up here now. Tracheitis. Okay, so bacterial. All right, so Staph aureus, pick a good anti-staph antibiotic. Epiglottitis, most common bacteria, still H. influenza B. What do you see on the neck film? The thumb sign, which is a swollen epiglottis. We had one morning question where I showed you that. It looks just like a thumb. What if you saw a steeple sign? A B. Group. This is epiglottitis, different. So what do you see here? Fever, which into looking at that, Steve. IL-1, maybe by what cells, Sabu? Huh? IL-1, maybe by what cells? IL-1, maybe by what cells, Maria? Macrophages, don't forget. All right, so fever, stridor, muffled voice. That's the epiglottis, keep closing off the area, it's so big. And then leaning forward, drooling. Classic 4 findings. When you suspect somebody has epiglottitis, what's the next step in your management, Leslie?
Protect the airway.
Protect the airway, intubate them right away. And your question, Leslie, was?
Question was, when we have a patient with a CAP already in the hospital, we
Yes.
use a mix of ceftriaxone and what was the other,
Azithromycin is the other one you put it with it.
azithromycin, right?
Yeah, correct. All right, so epiglottitis. Tracheitis, one unique cause is diphtheria. Remember, diphtheria has a toxin, and that toxin, if you remember, ADP ribosylase, we've talked about this already. ADP ribosylase EF2. And that's the most common question asked. What is this toxin doing again? Ribosylate EF2. Who else has that same toxin? Halima. Another bacteria has that same toxin as diphtheria. Melissa? And Zena. Pseudomonas. They're both ribosylate EF2. Okay? That one has a gray pseudomembrane, thick gray membrane. You'll see back there when they describe it. Easy point as long as you remember it. All right, what do you do with diphtheria? Secure the airway again, because that membrane is going to close off the airway eventually. The toxin, notorious for causing heart block. Remember one of the 5 infections that cause heart block. Name another one, Angie. Another infection that causes heart block. Not Coxsackie B. Cynthia. Infection that causes heart block. Nolan. And Amy. And Reed. Chagas. Legionella, Lyme, diphtheria, Chagas, and I'm missing one. Typhoid fever. Make sure you know the 5, folks, because only 5 infections out of thousands cause heart block. Yeah, I think it's pretty high yield. Huh? You know it's already in your notes, right? So it's Legionella, Lyme, diphtheria, Chagas, and typhoid fever. All right, now the different bacterial pneumonias and their clues. First one, strep pneumonia. First clue, rusty colored sputum. Rusty colored sputum, classic clue. Second, the only gram-positive with a capsule. If they say that, hey, I'm always happy, gives me a point. It's the only gram-positive with a capsule, folks. There are no others. Third clue, gram-positive diplococcus. That means it travels in pairs. The only one. So either they say diplococcus or they say travels in pairs. Hey, I get a point. They give you the culture results, folks. They don't hide it from you. That's why when we go through micro, I'm just going to give you key words. All they got to do is mention one of them. You should get a point. Strep pneumonia has 80 strains. Why would they ask you about that? To explain why Bobby keeps getting strep throat every week. Mom thinks you're not doing your job as a doctor. How come he coming back with strep pneumonia again and again? That's because it's a different strain. All right. Whenever you get antibodies, get antibodies to the strain that's in your body right now. You don't have antibodies to the other 79. Okay. But mothers are the most impatient gatekeepers. If you don't explain things to them, there's more flux movement of patients in pediatrics than any other field. Because mothers get irritated because you haven't taken care of it. They go to another doctor. By the time they get to the other doctor, Bobby got better on his own. Now she swears the other doctor's a lot better than you. Yeah, my other doctor, he just wouldn't give her Bobby something strong enough. Whatever that doctor just gave Bobby, she swears that's what's cured him. No, the kid got better on his own. All right, but anyway, you don't want to lose your female patients. Female patients are the best paying customers in medicine. Just so you know. Nobody likes to lose a female patient. They pay their bills. I mean, they're conscientious, all that. So that's the kind of patient you want to keep forever. All right, anyway, that's rusty colored sputum. All right, next one, Klebsiella pneumonia. Curing jelly sputum. Halima, what do you think of when you hear curing jelly stool? Melissa, curing jelly stool. Interception. It's the same Klebsiella. Just Klebsiella down in your colon, that's all, or ileum. So curing jelly sputum. First clue. Klebsiella. Second clue, loves homeless people and alcoholics. Now, I didn't say it was the most common. Because I've seen that question. They'll say, what's the most common cause of pneumonia in alcoholic? They know you're going to pick Klebsiella. No, it's just strep pneumonia. And I told you, don't read a vignette when they say most common. Just click what you always know is the most common. Skip the story. Because you're going to be tempted to change your answer just because he's an alcoholic, but your answer's wrong. All right. Klebsiella pneumonia. alcoholics, and homeless people. Third clue, likes to attack your fissures. Most bacteria like to be in a lobe. That's why it's called lobar pneumonia. This guy will attack the fissures. So that means he goes into the space between lobes. Very unusual. I've never seen that before until I read about this guy. Klebsiella. And then fourth clue, urase positive. A whole lot of those, you already seen it. BP punches, the mnemonic. And then last clue, has a capsule. One encapsulated gram negatives. Name another gram negative with a capsule. Mabel.
Strep pneumonia.
No, I said gram negative. Strep pneumonia is gram positive. Give me another gram negative with a capsule.
I don't know.
All right, Brenda Rivera.
Neisseria?
Neisseria is fine. Remember, some killers have pretty nice capsules. I give you the whole list. All right, so that's Klebsiella. Next one's actinomyces israelii. It's in your mouth. It's oral flora. So sulfur granules. Here's a clue. If you got sulfur granules, Rachel, what amino acid is it fermenting? Cysteine. So if they want to get out amino acid, you go down with them too. Okay? Sulfur granules. Second clue, abscesses of the face. So a facial abscess, always pick him. And that's why then you see the yellow flecks dripping out of his face. Classic. The nickname was lumpy jaw, which is an abscess, lumpy jaw. Actinomyces. Classic description, gram-positive filamentous. That means it branches out in so many different directions. Gram-positive filamentous. And all you need is plain old penicillin to cover him. So easy to treat. Okay. Next one. Seen after the flu.
Excuse sir.
Wait a minute, maybe let me do the last two. All right. The flu, this is flu season. If you see somebody dying from the flu, it's usually not the flu that's killing them, it's Staph aureus. Staph aureus loves to come in after you're recovering from the flu. 10 to 20,000 elderly people die every year from the flu. But they'll ask you what actually kills them is Staph aureus. It's not the flu itself. What do you see with Staph aureus? He has every enzyme, eats holes into your lungs. So you see multiple abscesses, or they'll call them pneumatoceles, air bubbles. Pneumatocele, air bubbles in the lungs, or abscesses in the lungs. Always think Staph aureus. And then malodorous smell or gas formation, pick anaerobes. The best coverage for anaerobes above the diaphragm, Leslie.
Clindamycin,
Clindamycin, below the diaphragm, Leslie.
Metro,
Metronidazole. So just so you guys know that. Now we'll go through all this again in micro. I'm just giving you a preview now as we go. Just so you hear the same antibiotics twice. Okay, but you gotta rehearse it and drill it, folks. There's no magic to this. I'm able. Now your question.
You said something about actinomycin is Larry, how to identify it. So give two examples. I was lost on that.
What? I said what?
It's like you gave two examples about actinomycin is Larry, right?
Israelia, yeah. I said it causes facial abscesses. They call it lumpy jaw. Or there's a hole in your face and yellow drainage coming out of it. That's the sulfur, cysteine. It's all actinomyces. The last clue, actinomyces, I forgot to say this one. PID caused by an IUD. That's an old question still floating around. I just saw it a few months ago, so I know it's still around. Okay. This was an old question a few months, not even a few years, many years ago, until even though it's been debunked. Actinomyces israelii is oral flora, right? What's it doing down in the vagina? It was some couples who have an oral sex, and the doctors, for some reason, when it comes to sex, they always feel queasy about it. I told you, they just, oh my God, actinomyces causes PID. No, it doesn't. It's just his oral flora got caught by the IUD, and so that's how they found it down there. But anyway, it's treated as plain old penicillin would kill it, so it's not a big deal. All right, Mabel, you have another question? I see your hand is still up.
Yes, sir. What did you say about anaerobes?
What did I say about anaerobes? Right there.
Yeah.
bad odor, smell, or gas. Anytime they say bad smell or gas, you want an anaerobe. Then I gave you 2 antibiotics that treats it. Did you hear that part?
Yes.
What's the best anaerobic coverage above the diaphragm?
Clindamycin,
Correct. What about beneath the diaphragm?
metronidazole.
There you go. Then you heard it. All right, Cynthia. What about anaerobic? Yeah, Clinda, and that's only if they want anaerobic coverage. Yes. All right, let's see. You got some hands up here. First person. Oh, Jay. Oh boy. Who's Jay Gabriel? Gabriel Lopez Rivera?
Yeah, Gabriel.
Yeah, go
I
ahead,
had a quick
Gabriel.
question actually. About Klebsiella. You mentioned something about air trapping in the lungs or something like that. It was pneuma something. Something
Oh,
that you could
no,
see
that's
on
what
imaging.
Staph aureus.
Oh, it was staph.
Pneumatocele. Yeah,
Pneumatoceal.
pneumatoceal. That
Okay.
means air bubble.
Air bubbles.
Or they'll
Okay.
say air fluid levels or abscess. They usually don't say abscess. They describe it and you got to know, oh, they're talking about an abscess. That's Staph aureus.
That makes sense. Okay.
Yeah,
Thank you.
no problem. All right, moving on. Interstitial pneumonias now. Those are all bacterial pneumonias. Now I'm going to give you a clue for the interstitial pneumonias. Are these people going to have trouble breathing in or out, Karina? Interstitial pneumonia is going to have trouble breathing in or out. In. Restrictive or obstructive? Restrictive. PO2 will be what? Low. Respiratory rate will be what? High. PCO2 will be what? Low. pH will be what? High. Tell me about the pulmonary capillary wedge pressure. High or low? Why is it going to be low? No, it's correct, but I want you to be able to explain it too. I don't want you to forget on the day of the exam, start thinking something else. All right, you did good. I just saw it in your eyes. You got the blood gas, you gave me with confidence. Yeah, I saw that you seen the physio. Use that physio. Hypoxia causes pulmonary vasoconstriction. That's wedge pressure. Wedge pressure is flow in the lungs. It's going to be decreased. So you had it right. That's all right. Connect to what you already understand. That's all you do. Okay, but good. Well done. Atypicals is the first family. You want to know what do you need to know about atypicals? They have no cell wall. That's what makes them atypical. Best treatment for atypicals. First line, Gloria. Yeah, macrolides. Our first line. This is why when you put them in the hospital, they say, give them azithromycin to cover atypicals too, because you can pick up some of that. All right, so atypicals. And macrolides first, then tetracyclines, then quinolones. Chlamydia. The age was the best clue. 0 to 2-month-old baby, chlamydia. He picked it up on the way out of mom. So they start out with conjunctivitis. Remember, that's where chlamydia goes. Attacks the eyes first, and then they get a pneumonia. So now when a child on them has conjunctivitis due to E. coli, or not E. coli, sorry, chlamydia, they say treat them with oral erythromycin because the pneumonia is coming. We usually use topical, but then that doesn't cover pneumonia. So they say use oral now. That way it covers both. If you use oral erythromycin in the first month of life, it predisposes to another problem around 4 weeks of age on them. Yeah, that one. What was it? Yeah, pyloric stenosis. It's pros and cons. You got to do it when you have to do it. But it's because macrolides irritate your stomach. If they irritate your stomach has to contract harder, and that's how that muscle hypertrophies. Yeah, so it predisposes them to pyloric stenosis, but right now it's more important to get rid of infection that could kill that child. So chlamydia, 0 to 2 months of age. The other clue for chlamydia, it's a parasite, so eosinophilia. That's chlamydia. Mycoplasma, age range 10 to 30, so adolescent or young adults. Second clue, cause of walking pneumonia. Means they walked in the ER sick and walked right back out sick because nobody knew what interstitial pneumonia was back then. When we found out what it was, and they went back and looked at the x-ray, it was all over the x-ray, but nobody knew that was interstitial pneumonia. When you listen to somebody's lungs, what are you listening to? Airway. You're not listening to interstitium. So that's why they didn't hear anything. So respiratory distress, but when I listened, normal. So we thought, okay, it's not pneumonia, but it was. Anyway, that's how mycoplasma got that term, walking pneumonia. Walk in with it, walk out with it. All right. Another clue for mycoplasma, cold agglutinin, cryoglycolemia. Remember, I am he. The M was mycoplasma. Mycoplasma. Next one, Legionella, after age 40. First clue, heating and air conditioning pipes. Outbreaks in high-rise buildings, hotels and motels. So anytime there's an outbreak of pneumonias and people in the same building, it's always Legionella. Because you got to go all the way up to their air conditioning system, swab it, and you see Legionellas everywhere. The one thing every apartment shares in the building is heating and air conditioning pipes. Goes through every apartment. So Legionella, that's your best clue. Second clue, love standing water. And that's what's in the pipes. Love standing water. Third clue, causes diarrhea before the pneumonia. Causes diarrhea before the pneumonia. Fourth clue, silver stains in the lungs. Legionella and pneumocystis, the only two silver stain in your lungs. You understand, Reed? All right. And then finally, heart block. 1 or 5 that cause heart block. Oh yeah, one new clue now, well, it's not really new, but I started putting in my lecture, is the charcoal yeast agar extract. It's the only thing that grows on this agar. Because I don't teach agars. But every time I've seen these 4 letters, I got a point for it. So that's why I started sharing it in my lecture now. All right, because all the other bugs, I'm not telling you agars, because agars are not specific at all. But this one is. So that's my Legionella story. Fungus. You've heard these before. Where you live tells you what fungus you ran into. Histoplasmosis, Midwest. That's where you're at now. Second clue, bat droppings. People who explore bat caves, apparently there's a lot of them in the Midwest. Spelunkers, yeah, they love going through the bat caves. They step on the bat droppings, and now when they take off their shoes, now in their hands, they end up ingesting it later. So histoplasmosis, bat droppings. Third clue is the only fungus that can live within macrophages. So anytime they say yeast form visible within macrophages, they already told you the answer. Histoplasmosis. Last clue is a warning. Even though his last name is capsulatum, he doesn't have a capsule. But they know a lot of students are going to fall for that because it ends in capsulatum. No capsule. Blastomycosis. Have a blast in the Northeast, so New York and surrounding states. Have a blast in New York. Next clue, pigeon droppings. Anybody here from New York? Yeah. Oh, Melissa from New York. Oh man, you guys got some of the meanest pigeons I've ever seen in my life. And man, they totally gangster, boy. I'm telling you, man. I'm used to Chicago pigeons, totally different up north. So in Chicago, you walk up on a pigeon, fly away. You're the bigger person. They say, we fly away. So my wife and I were in New York for a conference, and we're walking towards pigeons. I didn't think nothing of it. But then as I approach the pigeons, I don't see them moving. And these pigeons start looking at you like, what's up? What's the deal? You know, got their chest out. Yeah? What's with you? You're a tourist, aren't you? Hey, you know the deal here? All of a sudden you're like, honey, let's walk around them, okay? Let's walk around. I mean, the pigeons look at you like they're ready to fight you. Man, oh man. I'm like, whoa, this is a whole different breed of pigeons up here. All right, let's see. Muhammad Khan, question.
No, sir, just from New
Oh,
York.
okay. Mabel?
Sir,
Oh, you're from New
please.
York too? Or is that why you're at All right.
I'm not a gangster. Please, sir.
Where you
Apart
from, Mabel? Where do you live?
Georgia?
Oh, Georgia. Okay. So anyway, what's your
Sir-
question?
So please, apart from Ohio and Mississippi, which other state is in Midwest?
Midwest, you got Illinois, Wisconsin, Ohio. What's the other ones? Any of the states around those 3. I am completely geographically challenged. All right, I've learned more about the geography of America from fungus, from having to miss it many times, and then have to look on the what is it, map, and oh damn, I didn't know that was part of the Midwest. Okay, learn something new all the time. One student bought me this little cartoon map of the United States a long time ago because I kept missing it. Say, hey, I can't help it. I just don't know the map of the United States. Anyway, so plasmamycosis northeast, pigeon droppings was the second clue. Third clue is a series of bees, broad-based hyphae. Remember, big bud. You would think the new bud is a tiny bud coming off the big one. It's the other way. You got a small bud and you got a huge bud that comes off of it. Big, broad-based bud, whatever. That's blastome. Big cavitary lesion in your lung. This thing eats a big hole in your lung. And then black nodules on the skin. Nobody's got their name on the rash, but they always describe these little black nodules that they have. That's blastomycosis. Coccidiomycosis, southwest. In the books, it says California. So I knew California. So I ran into a question they put in Arizona. I was like, damn, okay, that ain't California. I missed it. So I looked at the map. Oh, damn, it's right next to California. Oh, okay. Then they put it in Utah. I said, hell, I don't know where Utah is. Must be some other bug. Missed it again. Then they put it in New Mexico. I said, New Mexico, I think that's way too far over here on the right side. I had no idea where these states were, man. Where was I in high school? I must have missed those classes, man. Because I can't remember where the states were. I've learned more about where states are by the fungus. I'm telling you, man, than any other time. Anyway, Southwest, it likes dry heat. Dry heat. So Arizona, California, real dry heat. It hides right underneath the sand. So whenever they have a sandstorm, people pick it up. Then they show up in the ER, short of breath. Second clue, thin-walled cavity. So a real thin wall. And then when they divide, they describe them as multiple spherules. They look like little marbles. But anytime they mention that word spherules, I know they're talking about coccidium. So just a few buzzwords, folks, that you rack up points. Just make sure you know them well. All right. Treatment for systemic fungus. All right. All systemic fungus, we do it this same way. Okay. Amphotericin B and 5-FC for the first 2 weeks for all of them. Just so you know, we don't change for any of them. For the first 2 weeks, everybody gets treated with the best drugs. Amphotericin B and 5-FC. And then you send them home on one of the azoles for another 2 months. The difference is this. The azoles block the synthesis of ergosterol, which is the lipid these guys have. Just so you see it spelled, ergosterol. Amphotericin B binds to ergosterol and messes it up. And 5-FC takes the place of cytosine, so that's easy to remember. We'll talk about them again in micro. So the azoles block the synthesis of ergosterol. That's why you got to use amphotericin B first and then switch to the azoles. Because if you block the synthesis of ergosterol, who's amphotericin B supposed to bind to? You never use a combination. Okay? The difference is this: fluconazole flew up to your brain, the best CNS penetration. So for CNS fungus, they expect you to send them home on this one specifically. Itraconazole, nothing big about that one. Ketoconazole blocks P450 more than any other. They're all once a day, so they all block P450, but he does it more than everybody else. And then voriconazole, remember, the best one against aspergillosis. So those are the only 2 times they expect you to pick that particular azole. For cryptococcals up in your brain, they expect you to pick fluconazole and send them home on. For aspergillus, they expect you to pick voriconazole. For any other fungus, pick any one you want. Yes, sir. Josh. Is it safe to assume that any 2 fat soluble drugs are going to impact each other's metabolism? Yes, that's true. No, the ones that block, the ones that activate, that's just memorization. Now, the majority fall in the middle. That's why it doesn't matter that you use 2 of them. Okay, but the ones that are real bad about blocking P450, that means they're going to elevate the levels of the other one. Then you can run into trouble. Huh? Is what based on affinity? Yeah, okay, yeah, the affinity for the enzyme. Yeah, for the P450, yes, correct. So that they don't expect you to know which one, I mean, how it does it, because I've never seen that question. But you need to know who can block it and who can rev it up. That we've been saying as we go. Okay. All right. So treatment for systemic fungi. Now you know how to treat all of them. All right. The rest of the fungus, the rest of the fungi we go through. Paracoccidio, South America. It's usually a businessman who's been in South America for a few months, comes back short of breath. Paracoccidio. And then ship's wheel appearance. It looks circular with spokes going through the middle like a ship's wheel, the steering. Aspergillus, we've done him 3 times already. Remember, moldy hair, moldy basement. Loves old TB cavities. There, you can actually see it rolling around. Looks like a fungal ball or aspergilloma. Likes to eat blood vessels. That's how you met him in vasculitis. Right? Sudden severe asthma in an adult. That's dad down in the basement cleaning up and didn't wear a mask, and now he's full of aspergillus. So aspergillus is a common one they're going to ask you about. And I already gave you voriconazole, works very well for him. Spore tricks, rose thorn. If you're a gardener or somebody who works in a flower shop, and then they get pricked on the finger by the thorn, you see a little red nodule. When it's just 1 or 2 nodules, we treat it with potassium iodide drops, Ki. And once it becomes systemic, once they got fevers and everything else, no, you got to treat it with amphotericin B and 5-FC. And then the pneumoconioses. Pneumoconioses, Miha, are lung diseases caused by what you do for a living. So there's a ton of them. But there's the 4 that they test all the time. Why do they ignore the other ones? Because all the other ones are too easy. All right. Bird breeder's lung. Gee, I wonder what he does for a living. Silo worker's lung. They don't ask about those. I'm talking about 40 years. I haven't seen a question about them yet. These are the 4. Why? Because you got to know what they do for a living. The other ones, they put it right there in the name. So that's you can figure that out. Okay. All right. So first, which one has the highest risk for lung cancer and the lowest risk for lung cancer? The lowest risk for lung cancer was anthracosis, coal miner's lung. When they factored out the smokers, there was no more risk left, which means it was smoking that was causing the risk. And the greatest risk is asbestosis. And they found if you smoke and you get exposed to asbestos, the risk is like 40%, 40 times. Relative risk of 40. That's huge. Asbestosis, number 1. Anthracosis, no risk factor, no risk for lung cancer. All right, starting with asbestosis, what does he do for a living? Number 1, shipyard worker. Shipyards have never been rebuilt in America. They're all over 100 years old. You know, the government always keeps trying to put it off, put it off, put it off. The problem is there's asbestos in all the pipes, all the shingles, all the columns. And that's why they made all the companies set up a $30 billion trust fund. That way those families can sue and get money for their loved one who died from asbestos or mesothelioma. All right. So shipyard work was number 1. Pipe fitter. That's a plumber. Roofer, shingles. Brake mechanic. Old brakes have asbestos in it. Brakes, brake mechanic. And insulation technician, the guys who put in and take out insulation. Now they use fiberglass for insulation, but before it was made out of asbestos. The most common lung cancer seen with asbestos exposure. Nicholas Brusher, do you know this?
No, I just take a guess at adenocarcinoma. I'm not sure.
All right, let's see what Divya says.
I am also not sure.
All right, it is bronchogenic adenocarcinoma. The way to remember that, just so you know, next time, sir, is the fibers got to be inhaled into your lungs before they get to pleural cavity to cause mesothelioma. Students pick mesothelioma because why? Because the book talked about it. You don't realize your brain always makes the assumption that what the book talks about is the best answer for everything they ask. It's not. 70% of the time is bronchogenic adeno, 30% of the time is asbestosis. Mesothelioma. It's just that if you've been exposed to asbestos and you get a pleural cancer, is mesothelioma almost every time, 95% of the time. But they didn't say it was the most common. Okay, so be careful. So asbestosis. Another problem with asbestosis, when the fibers hit your lungs, they get coated with iron. So they call them ferruginous bodies. So anytime you see this description, they already gave you the answer. Ferruginous, that means coated with iron. And then in the pleural cavity, they talk about pleural thickening, pleural plaques, Samoma bodies, all meaning the same thing. Name another tumor associated with Samoma bodies. Aisha, Seba.
I'm blanking.
All right, Sheena, Kapoor.
Papillary thyroid cancer.
Yeah, remember papillary carcinoma of the thyroid, SA, serous adenocarcinoma of the ovary, M&M, mesothelioma, meningioma. Those are the four. All right, make sure you, again, review clues, folks. It's all over your exam. Rachel. It's adenocarcinoma. Yeah, bronchogenic adenocarcinoma. Yeah. All right, that's asbestosis. Silicosis. First of all, glass blower or sandblaster. Remember, silicon is using sand. Glass blower or sandblaster. So guys who are working on bridges, you got to blast the bridge with sand. All right, they pick it up. Silicosis, the silicon poisons your macrophages and predisposes you to tuberculosis. Next, silicosis likes to attack the upper lobes. So to talk about upper lobe fibrosis, the middle and lower lobes look fine. Silicosis is notorious for floating up there. Bisonosis, cotton. Somebody who works in a cotton factory or picks cotton on a farm. The fibers flying all over the place. That's what they're inhaling. Bisonosis. And then berylliosis comes from beryllium, a metal. You get it from radio and television welders, the ones who weld them together. That's when it vaporizes. Or now in the aerospace industry, I heard there's a lot of beryllium being used there. So now we got 3 good clues for beryllium. Any questions on these guys? A couple of miscellaneous. Nocardia. Nocardia is the only gram positive that's partially acid fast. So it's the only one. That means it's called a point where I come from, if they say that. Gram positive, partially acid fast, that's it. There are no others. Treatment for this one, trimethoprim, sulfamethoxazole. So the ones who are specific, I'll tell you. The ones who aren't, I'll wait till micro to start talking about it. So nocardia. Nocardia likes to attack diabetics. That's his favorite people. Lung disease and sinus disease. Sarcoidosis, description, non-caseating granuloma. It just means non-tuberculosis. I told you, but they love sarcoid whenever they use that description. Large hyaluronopathy. Remember potato sack. They look like big potato sacks. High ACE levels, because there's ACE in the lung cells, so makes sense. High calcium, because granulomas produce 1-hydroxylase enzyme to make vitamin D. Sarcoidosis, high calcium. Anyway, the rule is, if you see sarcoidosis in a chest x-ray of somebody and they're asymptomatic, the answer is do nothing. Which means the drugs we use don't work for that long. That means if you use it too soon, then you got nothing to do. When they finally get symptoms, now they're going to die quickly. Remember, what's his name? Bernie Mac died of this. A couple other celebrities have gotten this. Anyway, so sarcoidosis. If they're asymptomatic, do nothing. That's the answer. If they're symptomatic, treat them with steroids. And then I found out steroids have 5 anti-inflammatory actions. And Zena is going to give me one. 5 anti-inflammatory actions of steroids. It kills them. It doesn't just suppress them. Make sure you use the word kill, though. Suppress is not the answer that you're looking for. Kills T cells and eosinophils. That's I-KISS. Give me another one, Karis. Inhibits phospholipase A, so you can't make arachidonic acid to go down prostaglandins oligotrienes. Maria. Inhibit macrophage migration into the area. They can't process any antigens. No inflammation. Saba. Stabilize endothelium. Fluid can't get out, and monocytes can't go into tissues, become macrophages. One more, Nolan. 1S. Second S, stabilizing endothelium. We already got. What's the second S? No. I is for inhibit macrophage migration. S is for something else. Amy. Stabilize mast cells from degranulating. All right, so sarcoidosis. Steroids is the only treatment that we have. Lung masses. Again, this is straight out your neoplasia lecture, but we're going to go through it again. Most common mass in children, hamartoma. What is a hamartoma, Bailey? Benign what? Abnormal growth of normal tissue. Very good. See, that's what I want. I want to hear the key words. Whenever I ask you guys a question, give me the key words. That way I know you'll see the answer when you get to the test. You give me some other general word, and I'm not sure you're going to see the answer when you get there. I want you to be able to see the answer. You click, move, get in and get out real fast. What's common mass in adults? Granulomas, from all these things that we just talked about. Granulomas involves what two cells, Ida? T cells and macrophages. And the most common tumor, adenoma, means glandular, but the lung has always been glandular. Central cancers now. When you're talking about cancers, we got two that are central and two that are peripheral. So the two that are central, that's how I know them. Squamous cell and small cell. Squamous cell, as we said earlier, produces PTH and is related peptide, not really your PTH. Your actual PTH is suppressed by this thing, since they do the same thing. So PTH related peptide suppresses your PTH. But what's going to happen to your calcium, Nate? Increase in your phosphorus. Decrease. Are you going to be more or less likely to polarize acid with high calcium? I thought calcium gets in the way of sodium. You don't want to lead with that. So it's less likely to polarize, unless you say atrium and thalamus, then you say more likely, but that's only for those two members. All right, so hypercalcemia with symptoms was the first step in your management. Anna. Hypercalcemia with symptoms. First step in management. Lewis, remember, dilute it down. Dilute it down right away. And then loop diuretics, so they pee it away. Yes, sir. No, the question is there a certain level where you have to add bisphosphonates? No, but we add them only for the real high numbers, to inhibit osteoclast activity. Because usually fluids alone takes it, diuretics will take care, make it pee away, and then you find the tumor. Hyperparathyroidism is, you see one parathyroid is swollen, the other three are shrunken. Take that one out, they're back to normal. Typically above 12. Yeah, typically above 12. All right, small cell carcinoma, remember, is where you get eaten Lambert from. This one is anaplastic, located usually at the carina, so the location usually gets away from me. And then it produces 4 hormones. Remember, Cushing's disease and then SIADH. If you got SIADH, what's the first line treatment for it? Josh? Not DDAVP. Shri.
I'm sorry, can you repeat the question? My mic's been going in and out.
Okay. So what's the first line treatment for SIDH, for the hyponatremia, seen SIDH?
Isn't it saline?
Nope. You're going to make the hyponatremia become worse if you give them saline. You don't do that. Margaret. How about Claire?
I don't remember, sorry.
Adonis.
The water deprivation.
Yeah, remember fluid restriction. ADH is holding on to water. Just restrict how much water they can drink. You can't hold on to water anymore. and they'll concentrate their own sodium back to normal. However, Davika, if you got hyponatremia less than 120 and you have symptoms, what do you do for that person?
Vasopressin?
Not vasopressin. Diamond.
I'm not sure.
All right, Latoria.
Hypertonic saline?
Hypertonic saline, 3% saline. And that's to get it back above 120. That way the seizures at least will stop. And then you fluid restrict and let it concentrate the rest of the way. What's the most common cause of SIDH, Mabel?
Sir, what's common cause of SIDH?
Yep, that's the question.
Hyponatremia?
No, it causes hyponatremia, but that's not what I asked. What causes SIDH? Gloria, pain is number one. So you're going to see a lot of it in the hospital, folks. People are in pain. All the ICUs have it. All right? They're in pain. Remember I told you every time you wince, even for half a second, you engorge your brain with blood. And then the brain says, okay, you need more volume to raise the MAP because ICP just went up. Remember the equation? MAP minus ICP. You got to, if you raise one, you got to raise the other. Just in that half a second, ADH is released. And that before you know, you got SIDH. All right. All right. That's the two central cancers. Then the other two are peripheral. Bronchogenic adeno is in the terminal bronchus. That's out in the periphery. And then bronchoalveolar, just the word alveolar, got to be out in the periphery too. Can't be anywhere else. You understand, Solange? You understand, Meha? All right. Then we have carcinoid syndrome. Remember the triad? Flushing, wheezing, diarrhea. If you have carcinoid syndrome, where are most of them coming from? Sandra, you have carcinoid syndrome. Where are most of them coming from? Where? Yeah, remember pancreas first, ileum second. Although most carcinoids are in the appendix, they just don't go anywhere. So be careful what question they're asking. Too much serotonin. Serotonin is made out of what amino acid, Adnan? Not tyrosine. Close out. Oh, didn't say the right one first. So tryptophan. Tyrosine is for the catecholamines. So you measure 5-HIAA in the urine. And then large cell adenocarcinoma is real rare. Any questions on that? Yes, sir. Central just means right along the midline, right along the trachea. Yeah, mainstem bronchi. Yep. So they'll say perihyla. Perihyla is midline. I told you all they do is play around with words to see if you knew the original. Risk factors for lung cancer, since we mentioned lung cancer several times, primary smoking is number one. The risk increases with the amount and duration. The more you smoke, the longer you smoke, the higher your risk. Remember I said if you stop smoking, after 5 years, your lungs look normal, but the lung cancer risk is still the same. After 10 years, the risk is cut in half. And after 15 years, your risk is back down to 1 to 3%. That's why we help people stop smoking. What's the best way to help people stop smoking? Steve, what are you picking? Nabupropion. Andres. Remember, a nicotine patch comes with a support group. Pick that one first. Then bupropion, then varenicline. Radon is number two. Radon is radiation coming up from ground from bombs they dropped way back in the 40s. Still in the ground and still coming up. Secondhand smoke is the person standing next to you smoking. Some of that smoke is coming to you. Side stream smoke comes off the side of the tip of the cigarette. That smoke has never gone through the filter, and so therefore has a higher risk. Whereas mainstream smoke is the one that draws through the filter and then blows in your face. You say, thank you very much, sir, for being considerate. At least you lowered my risk of lung cancer. I appreciate that. Anyway, it's crazy, but that's what happened. Secondhand smoke was shown to increase the risk of lung cancer on airline. What do they call them? What's the general term they use for them? The flight attendants. That's the general. Yeah, that's what I couldn't pick the term. Flight attendants. They used to have first 9 rows smoking. How about the 10th row? You're right next to the smoke. How does that stop? It was crazy, but that's what they used to have. And so the airline attendant who worked in that smoking section, they followed them for like 5 years. Their smoking risk for lung cancer risk was through the roof. It was like a relative risk of 8. That was huge. That's when they said, no more. That's how they stopped smoking on airlines. Because out of concern for the airline workers, they were dying of lung cancer like you wouldn't believe. Okay. All right. Pneumoconiosis. All the pneumoconias we just talked about, and I gave you highest risk and lowest risk for lung cancer. Any questions? Risk factors for lung cancer.
Yes, sir. I have
What?
questions, sir.
Yes, Mabel.
Please, sir, you said that the most common cause of asbestosis when it comes to lung cancer is bronchogenic cancer. So what do you say about mesothelioma?
No, that's wait a minute. You gotta put it in the right words. That's the most common lung cancer associated with asbestosis is bronchogenic adeno. Because the fiber's got to hit your lung first before they get to the pleural cavity. There's no way to go straight to the pleural cavity. That's how you know mesothelioma cannot be higher in prevalence than bronchogenic adeno. You understand that, Mabel?
Yes, sir.
All right. So Mabel, I just got one question for you. What's the most common lung cancer in somebody who works in a shipyard?
A shipyard is asbestosis.
That's not the answer.
Okay, in a shipyard, that isn't okay.
No
Mesothelioma.
problem. Nope, that's not the answer either. Let me ask Sabu. Bronchogenic adeno, still not the answer. Maria, it is metastasis. I told you guys about that question. Most common, you better ignore what comes after that. So you guys are going to read the vignette and end up picking the wrong answer by accident. Be careful. Most common is most common is most common. Metastasis is still the most common. Even if you're a shipyard worker or not a shipyard worker. They set it up by saying in a shipyard worker. That way you think about mesothelioma. But that ain't the answer. Most common. Okay, be careful. All right, so that's risk factors. Let's see, good place to stop. There we go, right on time. That way I do the physiology after lunch. Start back at 1:15.